Good evening, ladies and gentlemen. Okay, my topic is cholesterol is not the culprit for atherosclerotic cardiovascular disease. So as an interventional cardiologist, you must have noticed that many of your coronary artery disease patients have cholesterol within so-called normal range determined by NCP Committee of America. And many patients who have very high cholesterol have normal coronary arteries. It's been approximately 70 years that we have been believing that high cholesterol is the cause of coronary artery disease. And the reasons behind is that histopathology of atherosclerotic plaque, familial hypercholesterolemia, sugar industry of America, Ansel Keys 7-country study, Framingham heart study, and statin and PCSK9 inhibitor trials. But you might be surprised to know that none of these really prove that cholesterol is the cause of coronary artery disease. In this presentation, I would like to make a statement that cholesterol is not the cause for coronary artery disease, and that our understanding regarding cholesterol and coronary artery disease is probably completely wrong. And I'll give the evidences. So how cholesterol hypothesis originated? So in the beginning, it was the histopathology by Nikolai N. Anitskov in 1913, who found that cholesterol was present in atherosclerotic plaques, which we now call foam cells. But please remember that association is not always causation. It could be there for a completely different reason. And in 1938, familial hypercholesterolemia was described, and linked high blood cholesterol and heart attack in young people. And in 1964, the two forms, the milder one, heterozygous, and the more severe form, homozygous, was described. And looking back into the history, you can see how the sugar industry shifted blame to fat. Sugar was very important to British America because it was a big business. It dominated all exports, and money from sugar provided a momentum for colonization and required imported African labor slaves for sugarcane farming. And sugar symbol has always been symbol of prosperity and high status. That's why we always have dessert in the last. And even in Bengali culture, I think I don't have to tell you that misti is very important. And I don't know whether you remember or not that even during the lockdown period, Mamata Banerjee allowed strip shops to open. And there was an article in the New York Times which wrote, Sugar Association or trade group paid 3 Harvard scientists equivalent of $50,000 in today's value to publish a 1967 review of research on sugar, fat, and heart disease in NEJM. And you might be surprised that NEJM did not begin to require financial disclosures until 1984. And studies used in review were handpicked by Sugar Group, and it minimized link between sugar and heart health and created fear of fat. And there was Ansel Key, a nutritional scientist, who published a 7-country study. The study design was considered to be flawed by today's standards, but linked high dietary fat to heart disease, and the study became very influential. However, he had left 15 countries out of 22 and had cherry-picked only 7 countries that supported his hypothesis. And the very famous study, the 1948 Framingham heart study, which was followed up for 26 years, identified a number of factors related to heart health, like smoking, hypertension, diabetes, and high blood pressure. However, look at this Framingham curve. There is a big overlap between no coronary artery disease and coronary artery disease. And a substantial number of people with normal cholesterol levels less than 200 develop coronary artery disease, and a significant number of individuals with elevated cholesterol don't have coronary artery disease. But please notice in this graph that above 300, total cholesterol above 300, most of the people have coronary artery disease. And the reason is quite different, which I'm coming to. So those who have coronary heart disease have slightly higher median levels of blood cholesterol, but difference is small. Solberg et al. Noted this positive association between total cholesterol and degree of atherosclerosis disappeared when those with total cholesterol more than 350 were excluded. Now, we know that total cholesterol more than 350 is familial hypercholesterolemia, and reason behind their atherosclerosis is their inability to uptake LDL or inability to uptake cholesterol by the cell membrane. And then came statin trials in 1990s, and lowering cholesterol improved cardiovascular outcomes. That was what they tried to prove. For many experts, this trial proved the cholesterol hypothesis once and for all. However, the findings was exaggerated in terms of relative risk reduction, and absolute risk reduction were not so impressive. And look at this Pfizer's advertisement. It says Lipitor reduces the risk of heart attack by 36%, but in very small letters, which you cannot even see in this advertisement, in below, it's written that absolute risk reduction, however, is only 1%, not at all impressive. And came Jupiter trial of rosuvastatin, which was considered to be a landmark trial, and ACC/AHA formulated guidelines based on this trial. But if you look at this trial again, it is found to have statistical flaws and exaggeration. And at the same time, there were many other trials by the name of heavenly bodies, right? Asteroid, Corona, GCHF, Aurora, and all of them had failed to provide evidence that statin reduces coronary heart disease, but they were all ignored. So because of these, in 2010, 11.6 Americans were taking statins, and because of the 2013 ACC/AHA guidelines, an additional 10.2 million Americans became, without cardiovascular disease, became candidates for statin. And in 2014, 13.5% of Americans were taking statins. And statin consumption has increased all over the world. However, look at this WHO graph. However, death due to ischemic heart disease increased from 7 million per year in 2000 to 9 million per year in 2019, and it is still increasing all over the world. Then what is the cause of atherosclerosis? Then we'll have to go back all the way back to our anatomy class. Cell membrane is a bilayer of phospholipid, which all of you know, and it is the cholesterol that is interspersed in between, maintains integrity of the membrane. Without cholesterol, phospholipid would be oil at high temperature and butter at low temperature. Vascular endothelial cell membrane is prone to damage more than any other cell membrane in our body. That's because of the mechanical factors, which is also known as wall shear stress of blood flow and blood pressure, and chemical factors like advanced glycation end products of diabetes mellitus. Any sort of damage in tissue leads to inflammatory reaction, and endothelial cell membrane inflammation leads to atherosclerotic process. LDL cholesterol, the cholesterol circulates in blood, moving cholesterol to where it is needed for cell repair. And you also have noticed that bifurcation and curves, where the mechanical stress is the highest, are the segments that are prone to atherosclerosis. And if you go into the depth of familial hypercholesterolemia, it is the absence of defective LDL receptor on cell membrane required for LDL uptake. So in heterozygous, there's 50% absence, so LDL is more than 300 in the blood. However, in homozygous, there's complete absence of LDL receptor in the cell membrane, and that increases our cholesterol from 600 to 1,000 in the blood. That means there is inadequate cholesterol in cell membrane for repair in case of familial hypercholesterolemia, which results into damage and inflammation in early age. And you also need to know how statin works. Every nucleated cell has mevalonate pathway to produce their own cholesterol, because cholesterol is extremely important to maintain the integrity. So statin inhibits a key enzyme known as HMG-CoA reductase. So prolonged intake of statin results in very low level of intracellular cholesterol, and the negative feedback system upregulates the LDL receptor on cell membrane, which uptakes the LDL from blood, and that's how cholesterol decreases in blood. So LDL cholesterol is internalized through LDL receptor, is then redistributed in the cell and most being incorporated in the cell membrane. Therefore, statins increases cholesterol in cell membrane. So please note, statin does not decrease cholesterol. It increases cholesterol in cell membrane. And this is also proved by the following experiment. Experiment that has been published in Biochemica et Biophysica Acta has shown that cholesterol biosynthesis inhibitors decrease cholesterol content of cell membrane when cultured in lipoprotein deficient medium. However, when cultured in lipoprotein rich medium, the actual cholesterol content increased on the cell membrane. So my conclusion is that cholesterol is extremely important for cell membrane integrity. All nucleated cells obtain adequate cholesterol by de novo synthesis or exogenous cholesterol through LDL receptors, and atherosclerosis is initiated by inflammatory process. Cholesterol is in fact accumulate in plaques for the healing process. Please note, for the healing process. The small benefit of statin is because it increases cholesterol in the cell membrane. Thank you for your patience.
Thank you, Dr. Sanjay Kumar Shrestha, for your nice presentation. Now, I would like to request our chairperson for this session to conclude this session, some comment and conclude this session. Professor Noor Alam, Professor Mohammedullah Firoz, and Professor Govindo Paul.
Thank you, Dr. Sanjay Shrestha. And it's nice to have you back in Bangladesh always. We always feel good to have you with us. There are so many Nepalese cardiologists who are trained in Bangladesh. And you have given a very thought-provoking lecture. It is regarding the pathogenesis of atherosclerosis. In fact, the pathogenesis of atherosclerosis, the concept is being changed over the decades, which is the culprit one. And today, the most important one is the inflammation, systemic inflammation, or endothelial dysfunction, which is the main culprit, which causes the leakage in the endothelium, and that allows the cholesterol to enter into the subendothelial layer, and which exaggerates the inflammatory process, and all the inflammatory cells and markers are accumulated in the subendothelial layer and leading to this atherosclerotic plaque and all these things. And definitely this inflammation is a very good important initiating factor. Though cholesterol is we consider cholesterol culprit because it is getting accumulated in the atherosclerotic plate and it is reducing the lumen size. That's it. And the role of a statin is not only reducing the cholesterol level, it also reduces the inflammation. It also improves the endothelial function. That's why we are using more and more cholesterol and statins. And definitely you are right that there were so many risk factors which were identified in the Framingham study, and only smoking and salt were declared as the culprit, and later on sugar was also declared as the culprit one. Thank you for your great lecture. It will definitely help our audience to rethink about the atherosclerotic process, why we are using these statins, and how these atherosclerotic plaques are being formed. Thank you very much.
Me presenter.